Peripheral vascular disease. Peripheral arterial disease. Peripheral vascular disease is commonly caused by atherosclerosis and usually affects the aortoiliac or infrainguinal arteries. It is present in 7% of middle-aged men and 4.5% of middle-aged women, but these patients are more likely to die of MI or stroke than those their legs. Now, limb ischemia. Limb ischemia may be classified as chronic or acute. Chronic lower limb ischemia. Common risk factors are smoking, diabetes, hypercholesterolemia, hypertension. Premature atherosclerosis in patients aged less than 45 years may be associated with thrombophilia and hyperhomocystinemia. Now, the clinical features. Symptoms. Peripheral arterial disease can be described using the Fontaine classification. Stage 1 asymptomatic, Stage 2 intermittent claudication, Stage 3 rest pain or nocturnal pain, Stage 4 necrosis or gangrene. Patients with intermittent claudication complain of exertional discomfort, most commonly in the calf, which is relieved by rest. Patients with aortoiliac disease may experience pain in the buttock, hip or thigh and may notice erectile dysfunction. The claudication distance may be reproducible. Patients with rest pain experience severe unremitting pain in the foot, which stops a patient from sleeping. It is partially relieved by dangling the foot over the edge of the bed or standing on a cold floor. Patients with severe peripheral vascular disease or critical lower limb ischemia may have ulceration or necrosis of the tissue, that is gangrene. Signs. The lower limbs are cold with dry skin and lack of hair. Pulses may be diminished or absent. Ulceration may occur in association with dark discoloration of the toes or gangrene. The abdomen should be examined for a possible aneurysm. Differential diagnosis. Symptoms may be confused with those of spinal canal claudication, but all pulses are present. Osteoarthritis, hip or knee pain often at rest. Peripheral neuropathy associated with numbness and tingling. Popliteal artery entrampment. Young patients who may have normal pulses. Venous claudication. Bursting pain on walking with a previous history of DVT. Fibromuscular dysplasia. Burgess disease, young males, heavy smokers. Now the investigations. An estimation of the anatomical level of disease may be possible with the examination of pulses. The severity of disease is indicated by the ankle brachial pressure index ABPI. This is a measurement of the calf pressure at which blood flow is detectable by Doppler in the posterior tibial or anterior tibial arteries compared to the brachial artery. Ankle brachial pressure. Intermittent claudication is associated with an ABPI of 0.5 to 0.9. Values of less than 0.5 are associated with critical limb ischemia. The sensitivity of the test may be improved by a fall in ABPI after exercise. If the arteries are heavily calcified and incompressible, that is in renal or diabetic disease, the ABPI will be falsely elevated. In these patients, toe pressure values are more sensitive. Diagnostic imaging includes the following options: digital subtraction angiography (DSA) provides an arterial map but requires peripheral arterial cannulation and exposes the individual to iodinated contrast. It should be reserved for use in patients immediately prior to intervention. Duplex ultrasound using B-mode ultrasound and color Doppler can provide an accurate anatomical map of the lower limbs with sensitivity of 87% and specificity of 94% compared to angiography, although it is operator dependent. Three-dimensional contrast-enhanced MR angiography provides excellent imaging of both legs with a single contrast injection without exposure to ionizing radiation. Sensitivity of 97% and specificity of 96% are reported. This is the angiogram showing occlusion of the right external iliac artery. CT angiography is an effective alternative to MRA, although extensive calcification may obscure stenosis. CT angiography requires ionizing radiation and iodinated contrast media. Now, management. Medical management. All patients with peripheral vascular disease need aggressive risk factor management. They should be encouraged to stop smoking and require smoking cessation advice. Individuals with diabetes mellitus need regular chiropody care and diabetic management. Hypercholesterolemia should be treated as this reduces disease progression. The heart protection study showed that even the reduction of a normal cholesterol level reduces mortality from cardiovascular disease. Patients with peripheral arterial disease and a total cholesterol of more than 3.5 millimole per liter should receive statin therapy. Low-dose aspirin reduces the risk of MI and stroke in patients with peripheral vascular disease. Patients should be encouraged to exercise and to avoid obesity. Pharmacological. Cilostazol is a phosphodiesterase 3 inhibitor that increases levels of cyclic AMP, produces vasodilatation and reversibly inhibits platelet aggregation. At a dose of 100 mg twice daily, it can increase walking distance in patients with short distance claudication. Neftidrofuryl is a vasodilator agent that inhibits vascular and platelet 5 hydroxytryptamine receptors and can reduce lactic acid levels. At a dose of 1 to 200 mg 3 times a day, it may increase walking distance and improve life. Oxpentyphylline, inositol nicotinate, and cinnarizine are not recommended for patients with claudication. Surgical or radiological. Vascular intervention for stable claudication is not generally recommended except in patients with severe or disabling symptoms. Percutaneous transluminal angioplasty is the first option. It is carried out via catheter inserted into the femoral artery. The long-term patency rates decreases as the angioplasty becomes more distal. The long-term results of angioplasty appear to be similar to those of a continued exercise program. Arterial stents may be deployed in recurrent iliac disease. and drug-eluting stents allowing long-term patency are being used with paclitaxel, for example. Bypass procedure may be performed using Dacron, polytetrafluoroethylene, or autologous veins. Bypasses to distal vessels have poorer long-term patencies. Prosthetic grafts have equal patencies in above-knee bypasses but are inferior to grafts to veins below the knee. In severe ischemia with unreconstructible arterial disease, an amputation may be necessary. An amputation may lead to loss of independence. Only 70% of below knee and 30% of above knee amputees achieving full mobility. Now, acute lower limb ischemia, clinical features, symptoms. Patients complain of the 5Ps: pain, the fact that the leg looks white, pallor, paresthesia, paralysis, and the sensation that it is perishingly cold. The pain is unbearable and normally requires opioids for relief. Signs: the limb is cold with mottling or marbling of the skin. Pulses are diminished or absent. The sensation and movement of the leg are reduced in severe ischemia. Patients may develop a compartment syndrome with pain in the calf on compression. Etiology: acute limb ischemia may occur because of embolic or thrombotic disease. Embolic disease is commonly due to cardiac thrombus and cardiac arrhythmias. Rheumatic fever is now an uncommon cause, and the frequency of cardiac embolic acute limb ischemia is also on the decline. Emboli may also occur secondary to aneurysm, thrombus, or thrombus on atherosclerotic plaques. Emboli from atrial myxomas are rare. Acute limb ischemia is now often due to thrombotic disease. Acute thrombus usually forms on a chronic atherosclerotic stenosis in a patient who has previously reported symptoms of claudication. Thrombus may also form in normal vessels in individuals who are hypercoagulable because of malignancy or thrombophilia defects. Prosthetic or venous grafts may also thrombose either de novo or secondary to a developing stenosis, which may be in the graft or in the native vessels. Popliteal aneurysm may thrombose or embolize distally. Acute upper limb ischemia may be caused by similar processes or occur secondary to external compression with a cervical rib or band. Investigations are similar to those described for chronic lower limb disease. Medical management is dependent on the degree of ischemia. Patients showing improvement may be treatable with heparin and appropriate treatment of the underlying cause. Patients with emboli following MI or atrial fibrillation need long-term warfarin. Surgical or radiological. Patients with mild to moderate ischemic symptoms who have an occluded graft may need graft thrombolysis. Intra-arterial thrombolysis may reveal an underlying stenosis within a graft or native vessel that could be treated with angioplasty. Patients with an embolus may benefit from its surgical removal. Embolectomy. A bypass graft may be required after occlusion of a popliteal aneurysm or acute or chronic lower limb arterial disease. When an ischemic limb is revascularized, the sudden improvement in blood flow can cause reperfusion injury with release of toxic metabolites into the circulation. In muscle compartments, the consequent edema may lead to a compartment syndrome which requires fasciotomies, release of the fascia to prevent muscle damage. An amputation may be warranted in unreconstructible or severe ischemia. In patients dying from other causes, acute limb ischemia may occur and intervention may then be inappropriate.